Good afternoon, everyone. Today I'll be presenting my comprehensive cardiopulmonary case integration project for James Moore, a 62-year-old male recovering from an anterior ST elevation myocardial infarction and 3-week vessel coronary artery bypass graft surgery. This presentation focuses on developing a safe, evidence-based 6-week exercise program that transitions him from supervised phase 2 cardiac rehabilitation into early phase 3 independent exercise. James Moore is a 62-year-old male who is entering phase 2 cardiac rehabilitation 6 weeks after an anterior stem eye and 3-vessel coronary artery bypass graft surgery. His medical history includes hypertension, dyslipidemia, a previous smoking history, and sedentary lifestyle, all of which increase his risk for future cardiovascular events. Although he is medically stable and independent with daily activities, he continues to experience mild shortness of breath, fatigue, and decreased endurance. James also reports anxiety about exercising because he worries that he could damage his bypass grafts or overwork his heart. This concern is common after a cardiac event and makes patient education an important part of rehabilitation. So James currently takes metoprolol, lisinopril, atorvastatin, aspirin, and clopidogrel. Since metoprolol is a beta blocker, his heart rate response during exercise is reduced, making heart rate a less reliable way to monitor exercise intensity. Instead, I primarily use the Borg rating of perceived exertion scale with a target range of 11 to 13, along with monitoring blood pressure, symptoms, and dyspnea throughout each session. James completed a symptom-limited modified Bruce treadmill test and achieved a peak heart rate of 108 beats per minute, a peak blood pressure of 168 over 84, and an estimated VO2 peak of 19.8 millimeters per kilograms per minute, or 5.7 meds. The test ended because of fatigue and shortness of breath rather than the dangerous cardiovascular symptoms, indicating an appropriate response for someone recovering from a recent myocardial infarction and bypass surgery. Additional testing supported these findings. James walked 420 meters during the 6-minute walk test, completed 20 repetitions on the 1-minute sit-stand test, and recorded a time up and go score of 9.8 seconds. Together, these results show that reduced aerobic capacity but adequate functional mobility, confirming that he is ready for a supervised exercise program with gradual progression and careful symptom monitoring. So James demonstrated several normal physiologic responses during this exercise, one of which was his systolic blood pressure increasing appropriately with the workload, which has remained above 95%, where there were no signs of exercise-induced ischemia. Although occasional premature ventricular contractions were observed during the later stages of testing, they remained isolated and did not progress into sustained arrhythmias, allowing exercise to continue safely with monitoring. The biggest factors limiting James's exercise tolerance were reduced aerobic fitness, recent bypass surgery, generalized deconditioning, and anxiety about physical activity. The findings supported using a conservative exercise prescription with moderate intensity, gradual progression, and close monitoring of the symptoms, perceived exertion, and blood pressure instead of relying on heart rate alone. Based on James' assessment, I developed a 6-week exercise prescription that gradually transitions him from supervised phase 2 cardiac rehabilitation into early phase 3 independent exercise. The program follows the FIT principle and includes aerobic exercise, resistance training, functional activities, flexibility exercises, and community-based exercise to improve overall cardiovascular health and daily function. This progression focuses mainly on increasing exercise duration and total weekly volume by about 10 to 20% while maintaining a moderate intensity that matches James' current fitness level and recovery status. So during the first 3 weeks, James participates in supervised outpatient cardiac rehabilitation. Aerobic exercise includes treadmill walking and recumbent cycling 3 to 5 days per week and approximately 25 to 35 minutes at an RPE between 11 and 13. Resistance training is introduced using light weights and resistance bands for the major muscle groups, while functional exercises such as sit-to-stands, stair climbing, and balance activities help improve daily movement and independence. Because this phase is supervised, each session includes monitoring of blood pressure, ECG when appropriate, symptoms, perceived exertion, and dyspnea. Patient education is also a major focus during this phase, so James can learn how to recognize normal exercise responses, identify warning signs, and build confidence as his endurance gradually improves. During weeks 4 through 6, the program shifts towards greater independence while maintaining safe progression. Aerobic exercise increases to approximately 40 to 45 minutes on 5 to 6 days each week, while outdoor walking becomes the primary activity. Resistance training progresses to moderate intensity as tolerated, and James is encouraged to participate in community walking groups or exercise with family members to improve long-term adherence. As supervision decreases, self-monitoring becomes more important. James is taught to use the Borg RPE scale, recognize symptoms that require stopping exercise, keep an exercise log, and understand when to contact his healthcare team. These strategies help prepare him for long-term independent exercise while maintaining the safety principles established during phase 2 rehabilitation. A successful transition from phase 2 to phase 3 depends on more than completing 6 weeks of exercise. James should demonstrate stable blood pressure responses, no signs of exercise-induced ischemia, appropriate recovery after exercise, and the ability to exercise at the prescribed intensity without excessive fatigue or symptoms. He should also feel confident monitoring his own exercise and recognizing when to stop or seek medical attention. If James develops an abnormal response, such as unusual fatigue, chest discomfort, dizziness, or an RPE that is much higher than expected, I would reduce the exercise intensity or duration and reassess his symptoms. If the symptoms continue or any concerning cardiovascular signs develop, exercise would be stopped and the supervising physician would be notified before progressing the program. Patient safety remained the highest priority throughout this exercise program as well. During phase 2, I would monitor blood pressure, perceived exertion, dyspnea, symptoms, and ECG when appropriate. As James transitions into phase 3, the focus shifts towards teaching him how to monitor these responses independently while continuing to exercise within his prescribed intensity range. Exercise should be stopped immediately if James experiences chest pain, severe shortness of breath, dizziness, fainting, sustained arrhythmias, or abnormal blood pressure responses. In those situations, I would assess his condition, follow the facility's emergency procedures if needed, and communicate any significant findings to the supervising physician before allowing them to return to exercise. As a clinical exercise physiologist, my responsibility is to develop safe exercise prescriptions, monitor physiologic responses, educate patients, and document progress. It is also important to recognize the limits of my scope of practice. I would never diagnose new medical conditions, adjust medications, or make medical decisions that should be managed by a physician. Successful cardiac rehabilitation depends on teamwork. Throughout James' rehabilitation, I would communicate regularly with the cardiologist, primary care provider, nurses, physical therapists, and other healthcare professionals to report his progress, discuss any concerns, and ensure everyone is working towards the same treatment goal. Because James is anxious about exercising after his heart attack and bypass surgery, clear communication is essential. I would explain that his exercise program is designed to safely strengthen his heart, improve his endurance, and lower his risk for future cardiovascular events. I would also teach him how to use the Borg RPE scale, recognize warning signs, and understand when exercise should be stopped. To improve long-term adherence, I would encourage James to set realistic goals, keep an exercise log, and involve his family in recovery. Since he enjoys walking and has a strong family support, these strategies can increase motivation and help him continue exercise after formal cardiac rehabilitation is complete. Christian values such as compassion, humility, integrity, respect, and service support ethical, patient-centered care. These values remind me to keep every patient with dignity, listen to their concerns, and provide care that is both evidence-based and respectful for their individual needs and their goals. For James, this means encouraging him throughout his recovery, communicating honestly about his progress, and working collaboratively with both his family and the healthcare team. Combining professional standards with compassion helps build trust, improve patient confidence, and supports better long-term outcomes. All in all, this six-week exercise program was designed to safely transition James from supervised phase 2 cardiac rehabilitation into independent phase 3 exercise. By using current clinical guidelines and gradually progressing aerobic, resistance, functional, and community-based exercise, the program addresses both his physical limitations and his anxiety about returning to activity. The long-term goal extends beyond improving exercise capacity. By promoting education, self-monitoring, confidence, and lifelong physical activity, this program helps reduce James's risk of future cardiovascular events while improving his overall health and quality of life. Thank you for your time.